Okay. So this is our second presentation this fall 2020 seminar series. I'm Zoe Mushkat, the health psychology intern at Jesse Brown. On behalf of Northwestern University's Feinberg School of Medicine and Jesse Brown VA Medical Center in Chicago, I'd like to welcome you all to our 2020 Health Psychology Seminar Series. We have a great lineup of health psychologists, and the seminars will be every week on Wednesdays at 2:30 p.m. Central Time through December 2nd. We're very happy that everybody could join us today. If you don't mind, please just type into the chat box that tell us where you're joining us from, and also tell us if you're in a grad program or a certain medical center. And then we can have a great sense of who's tuning in. You can also type questions throughout this presentation into the chat box, and I will take note of them, and we can go through at the end during a Q&A. I'm honored to introduce Dr. Sarah Thilges, Assistant Professor at Loyola University in the Department of Psychiatry and Behavioral Neurosciences section of Psychosocial Oncology. Dr. Thilges completed her bachelor's degree at the University of Iowa and her PhD from the Illinois Institute of Technology. She completed her internship at the University of Wisconsin Hospital and her fellowship at Loyola University Medical Center. Dr. Thilges is an expert in psycho-oncology for clinical work and research focused on stressors and resiliency factors during cancer, as well as family and couple dynamics and role shifts in patient-caregiver relationships. Please join me in welcoming Dr. Thilges.
All right. Thanks, everybody. I thought I just saw that Dr. Hooden is on this call, so that makes me very nervous because she is really a leader in psycho-oncology. But so I will share my PowerPoint, hopefully. All right. Okay. I'm assuming this worked. Okay, thank you. Yeah. So I realize that this is going to kind of seem all over the place because I really love psychosocial oncology, so it's really hard for me to limit or narrow down what I talk about. So this is going to be kind of a to Z look at psychosocial oncology, and of course I'm always looking to recruit people to our world, so there might be an aspect of what I talk about, something that is involved in our role that inspires you to either learn more or if you're already in the field, reiterates what your experience is. So we'll talk about some of the common responses to cancer. We're going to talk a lot about sexual functioning, caregiver burden or caregiver distress, some of the different treatments that we have for cancer-related distress, and then talking about grief and terminal illness and some of the challenges of both caring for patients at end of life and some of the provider impact in that area. So I realize that this is kind of a big, messy slide, but this was something I saw a few years ago, and I liked it because it really talks about the multiple ways in which psychology can be involved in the cancer continuum of care. So there can be everything from, when patients are seeking genetic counseling, pre-diagnosis. We see patients who are referred for prophylactic mastectomies or hysterectomies if they have family history of breast or ovarian cancer and a genetic makeup that would be concerning for cancer risks. So we do see patients to assess mood prior to surgeries like that. We also, thinking about at the time of diagnosis, is usually a time of high distress for patients, and we may be referred or asked to see patients who are newly diagnosed. Of course, at any point during treatment, most treatments have considerable physical side effects, which can impact quality of life and mood. Even during the period of survivorship, there may be a recurrence that happens for patients, or it may just be the fear of recurrence that motivates them to see us. Even for patients who do medically really well after treatment, there still can be a lot of ongoing emotional or psychological challenges during survivorship. One of the most common we hear is that, family and friends are ready to move on and celebrate being done, and the patients themselves, maybe for the first time, because they've been so focused on treatment, are thinking about the emotional damage of everything they just went through. Also, again, psychology could be involved in palliative care or end-of-life needs for patients, and then bereavement support for family members or friends who have lost somebody due to cancer. This was, again, I saw another nice graph looking at some of the responses to cancer. So we think that, again, maybe half of people are going to have quote unquote normal responses to cancer. So it may be the patients who talk about feeling a little worried, feeling a little down, but nothing that potentially is even diagnosable. Excuse me, or things that might respond with coping skills and support that they already have. However, a certain percentage of these will fall into the adjustment disorders category. And I think anytime you're looking at prevalence, that's why you can see huge ranges where studies will say, 5% of the population were depressed versus 80%. It just depends on how it's measured, how you're looking at it. So these are all kind of rough estimates. But adjustment disorders, so where the cancer itself is the stressor and we see it resolve as they get further out from completion of treatment, a certain percentage will develop kind of a full major depressive episode. We do also see delirium fairly common in patients undergoing cancer care, especially inpatients. And importantly, I always remind our students that hypoactive delirium can look a lot like depression. So inpatient will often get consults for patients that they describe as unmotivated or withdrawn. And then when we see them with, a cognitive screener or just more of an assessment, we find that it may actually be a delirium rather than depression or lack of motivation that's impacting their presentation. Anxiety disorders. And later on in my talk, I'll specifically look at anxiety with radiation because I think that tends to be one of the most common areas that we see a lot of anxiety. We do see personality disorders, which can always complicate medical care. Those are often the consults you get from physicians where they say, I just don't know what to do with this patient, or this patient's driving me crazy. Or we can see issues where maybe patients are alienated from their support system because of personality disorders or challenges that impact care, and then major mental illness, so things like schizophrenia. Unfortunately, of course, just overall in the population, this is a smaller percentage of patients, but I think medically we often don't see a lot of patients with really serious mental illness because they may not be seeking the routine care that would help them to be diagnosed with the cancer, or sometimes we'll see patients who just can't follow through with treatment and unfortunately kind of get lost to the system because of the impact of their psychiatric conditions. So when we're assessing depression in patients with cancer, we know that depression, and I love talking to a audience, like you already buy in, you know that depression matters. It's really important in even some of the medical outcomes. So we know that depression is associated with things like being in the hospital longer, having poor functioning or performance status at discharge. Can also be linked to decreased survival time and increased mortality. And some of the challenges with this is teasing apart, are patients more depressed because they're sicker, or is the depression kind of its own entity impacting survival? But there are some studies that even when they control for disease variables such as disease stage or the correlation with being older, find that depression still can be a standalone factor in predicting increased mortality. We don't always know why. It could be a direct impact, that during chronic stress, the HPA axis, the immune system is impacted. So it could be that, biologically on an immune cellular level, patients are less able to fight when there is depression. There also could be indirect effects too, right? So patients who are more depressed may be less adherent with medication. They just don't have the motivation or the energy to take their medication, do their therapy. They may also have less support. All these things, kind of the bidirectional nature, right? So patients it's hard to support people who are really depressed, so they may find their support system kind of falls away, or they have less support and they're more depressed. So again, like we said, it's really hard to get good prevalence rates of depression, but we know that in general, it's higher than it is in the general population and potentially even up to double according to some studies. So again, differences based on the tool that we use, self-report versus a more formal assessment. Some of the measures that we can use, the HADS, the BDI, the PHQ, are probably the most common ones that people will use in clinic. I'll get into some of the challenges with that. So if you guys think about the PHQ, there's heavy emphasis on the somatic symptoms of depression, right? It talks about fatigue. It talks about changes in appetite, slowed movement. Well, what are things that we know are related to cancer treatment? Lack of appetite, fatigue, changes to sleep. So, you can have patients, if you look at the PHQ, sometimes it's nice to see this in front of you. If somebody selects, nearly every day just on the somatic symptoms, they could show up as moderately to severely depressed, even without endorsing the emotional symptoms. So unfortunately, some of those measures can overestimate depression or kind of misattribute depression. So we still use them, right, because they're the most well-known screeners, but there is some ways that you can kind of assess or substitute some of the somatic symptoms for symptoms that would be more indicative of a cognitive or emotional depression. So instead of change in weight or appetite, you could ask about a depressed appearance. Patients who are maybe unkept, even just their physical appearance, shoulders drooped, not making eye contact, head down. We wouldn't necessarily expect to see that with chemotherapy. Instead of sleep disturbance, looking at if patients are more socially withdrawn, not talking to the people around them, loss of energy or fatigue. Instead, are patients feeling more pessimistic, negative self-worth. They're having difficulty in thinking or concentration, again, which could be related to chemotherapy. Instead, is there a lack of enjoyment from situations they would normally enjoy? And again, looking at, so the SIGI CAPS is something that they use a lot in the medical school or medical training to look at some of the depression symptoms. So change in sleep disturbance, loss of interest, increased feelings of guilt, decreased energy, concentration, changes to appetite or appearance, psychomotor agitation or retardation, or thoughts of suicide. Some risk factors for depression, and this is specifically within cancer, is of course a past history of depression, which is why we always get a psychosocial history when we talk to patients. Family history of depression, a recent bereavement, so if they've recently lost somebody. And this is not uncommon to see. Very often we'll see people who may have been a caregiver for a spouse or a parent for the last year or two and had potentially been putting off their routine screenings, or they had, a change in bodily function or a pain or something they were concerned about, but just didn't have the time to care for it. After that person has passed, they call their PCP, go through workup, and then find out they have cancer. So that's not an uncommon experience to have happen. Also, patients who have a substance abuse history, we know may be more at risk for depression. Patients who present as demoralized. So this is a big one, and it's sometimes hard to directly measure this, but, patients who, it's somewhat of a hopelessness, but also just kind of feeling like life has gotten them down. So sometimes you'll hear patients who have had a lot of stressors in their life say, each time I get back up, I get knocked back down. And when patients use language like that, that's kind of a red flag for me, either to assess more for depression or be aware that they may be at risk for depression. Some social factors. So there's some indication that younger age may be a risk factor for depression. could be related to the fact that, when patients are 25, they don't expect to be facing a major medical issue. And there's also a sense of loss on peer normative behavior they're doing. If their friends are, going out to the bar, or their friends are getting married or having kids, and they're, going through infertility related to cancer treatment and, asking, well, who would want to date somebody who's sick? And, there's a sense of missing out. Gender. So we know that, again, a lot of research says that women are more at risk for depression. My argument with anything gender and psychology related is that it may just be that women are more able to endorse depression. I don't necessarily know that we can equivocally say that there's difference based on gender. People who have less social support, and if they have other life stressors as well are all risk factors. Some cancer-related risk factors for depression. We know that the treatment phase can be a risk factor. So, we do tend to see a little bit of a sloping curve where depression is highest, at the time of diagnosis during treatment. And then assuming treatment is successful and they're recovering, depression does tend to remit over time. Patients who have an advanced disease are more at risk. It could be the physical impact of the disease or the treatment is more substantial, causing depression or more fears of prognosis. There's also some indication that the specific type of cancer may be more at risk. Like I cited this study looking at lower rates in lung cancer versus GI cancers. Again, could be maybe quality of life issues. So patients who have a GI cancer may not be able to eat. Usually there's a lot of pain associated with that, may also impact depression. I've always found it interesting. Pancreatic cancer is generally held up as a specific cancer diagnosis with a high risk of depression. So pancreatic cancer itself usually has a somewhat poor prognosis, so that could be a piece of it. I am not like a cytokine immune function psychologist researcher, but there's some concern that some of the kind of biological processes of the pancreas, so regulating functioning may impact depression as well. So again, I cannot speak eloquently to this, but if you want to look into it, I just know that the research exists. And then neurological disorders. So patients who maybe have secondary CNS disease, central nervous system disease, where it impacts ability to walk, impacting memory, concentration. Those may also be increased risk for depression. Some of the issues related to treatment. So we know uncontrolled pain is a huge factor which may lead to depression. Also again, we sometimes see patients who present as depressed, and then with further workup, it's found that their potassium is really low, or patients may present as confused, and it turns out they have really, really high sodium, urinary tract infections, those kinds of things. So which could all be caused by treatment, may also manifest as depression symptoms. We know endocrine issues, so hyper or hypothyroidism, may also present with kind of like low motivation, low energy. Corticosteroids, so that can trigger the depression pathway. We also look at just steroids as a part of treatment, can lead to anxiety disorders or panic attacks with patients. And we know that just the suppression of the chemotherapy itself, when you have no energy from your treatment, it's also just pretty hard to have an active and engaged mental and emotional state when you're just completely depleted physically. So looking at, like I said, I was going to specifically look at anxiety with radiation because I think that gives a cleaner picture of what it looks like. So again, we know that anxiety can be a significant predictor of decision to treat. And this one study specifically looked at men with prostate cancer. I had just mentioned to Isha about a former patient she saw, but we actually have a patient I was referred today who is has been unable to complete radiation. They've tried 3 different times, and her anxiety is so debilitating that she can't go through with the treatment. And so we're at a point where if we can't help her with that, she will not be able to get radiation, which has concerns for disease impact. I'm sorry, there's a typo here. It should be within head and neck cancer patients. The patients who reported feeling lonely or vulnerable during the treatment itself. So for those of you who aren't familiar with what a radiation procedure looks like, it varies a little bit depending on specifically where the radiation is being targeted. But you're generally alone in a room on a table with a window that the radiation techs and providers are looking at you. But it can, if you're already anxious about the procedure itself, it can feel very very foreign, very isolating. This study also too, sorry, it should be moved over, within this head and neck cancer patients found that during treatments, patients would tend to ruminate on their disease. So, you're in some circumstances, you're kind of strapped to the table so you don't move during radiation. So that was an opportunity for patients to kind of ruminate, is this going to work? Is this going to be effective? Thus heightening the anxiety. Again, head and neck treatment, I mentioned, depending on the cancer site, treatment looks a bit different. But for head and neck cancer, majority of those treatments, patients are fitted with a mask. It's kind of made of a metal mesh material that's molded to their face, their head, and sometimes their shoulders, and then bolted to the table so that they don't move during the treatment. So even just describing that, and I actually had a patient who brought his mask to our session at the end because he planned to take it out to a shooting range and shoot it when he was done with treatment. But just seeing the mask was anxiety provoking, and imagining wearing that for, patients sometimes do 20, 30, 40 sessions of radiation. So it's kind of a situation that's hard to imagine not feeling anxious during. Some of the interesting studies I found looking at anxiety is looking at how quality of life was related by patients versus providers. So you'll see that providers give patients performance scores, right, which is their measure of how well the patient's functioning. And then if we were to ask patients about quality of life, those two aren't always aligned, right, where objectively the provider says, oh, they can walk, they can carry out normal functioning, and a patient may say, I can't hold my granddaughter, and that thus makes my quality of life terrible. We know that the quality of life scores are tied into anxiety and distress. So patients who are more distressed are more likely to report quality of life as lower than what it is. Trying to be mindful of time too. I have a particular interest in medical trauma. So thinking of that as both patients who experience their medical treatment as a trauma and also patients who enter into treatment with a previous history of trauma. So again, similar to variance in prevalence we saw with depression and anxiety, we know that rates of cancer related. So when I say cancer related, I mean where an aspect of the cancer experience is serving as the trauma. So it could be for some patients, the way they were diagnosed serves as a trauma and meets all the hallmarks of a trauma. Other patients, it's an aspect of the treatment itself. So rates vary 4 to 35%. But when we look at even patients who don't quite meet the full diagnostic criteria, but have some trauma symptoms, rates go up quite a bit and can persist even 4+ years after the diagnosis. So this could be a little bit different. We saw that one study that looked at how depression scores remit, over the course of a year, but it may be that some of the trauma symptoms last longer. Untreated may lead to increased psychological morbidity and ultimately even mortality. Some of the variables that predict cancer-related PTSD, so same thing we talked about, gender, women are more at risk. Age, again, younger patients. Also, having young children can be a risk factor. So I hear from a lot of patients who do have young children, this kind of feeling an increased desperation to live because of the need to raise their children, have their children remember them, be there for milestones. And if you think about a trauma, which is a exposure to a potentially life-threatening or life-limiting situation, if you have this increased urgency to live, not saying only having young children presents that, but it does present a unique angle to it that can increase the trauma of the diagnosis itself. A family history of cancer, which I think is relevant because we do often see this, but if they've watched a family member maybe suffer, have a lot of physical symptoms, pain, a long deterioration with their cancer, that can increase the trauma of their own diagnosis. But so these are all things we can't change, right? Things that we can change or intervene on are helping to increase social support and coping that can either help to treat the trauma symptoms or be protective against them. Again, specifically looking at radiation, because I think this is another, can go hand in hand with the anxiety. So there was a really, really well done study, this one here, that looked at trauma during radiation therapy for cervical cancer. And you can imagine, again, when I describe just globally what happens with radiation treatments for women who are getting treatments for gynecological cancers. You are in pretty vulnerable positions during radiation, and you're doing that for potentially, 3-4 weeks at a time. So both for women who have had a history of trauma or just that experience itself can be quite traumatic. However, hopeful, in a more hopeful vein, this study did find that feeling supported by the treatment team, having psychology on board, which is wonderful, and a positive attitude were helpful, specifically even just how well treatment was organized. So, the team who considered, okay, this is a difficult procedure for the patient. Let's have everything ready to go, get them in, do the treatment, get them out, versus if they felt like they were stumbling around, treatment was prolonged, kind of increasing their vulnerability, that was risk factors for acute stress or later PTSD. We know that prior history of trauma or abuse is a risk factor for then experiencing an aspect of the medical treatment as traumatic. So we always, every patient we see, we assess trauma history. And I have some patients who say, what does my Vietnam experience have to do with this? Or what does that previous sexual assault have to do with this? And I remind patients that, there's aspects of treatment that can lead to vulnerability, loss of control, loss of autonomy, a sense of other people manipulating your body in a way that's outside of your control. So all of those are aspects for kind of triggering past traumas where patients have maybe experienced similar feelings. Patients with a history of abuse were more likely to report claustrophobia during radiation, but there's not a lot of research specifically on kind of the course of cancer-related PTSD, and because we know our gold standard treatments for PTSD are prolonged exposure, which is 90-minute sessions, an hour of homework every day, something that patients going through treatment just physically are not going to be able to do. We unfortunately don't have a lot of research on interventions. I have an idea, so if anybody wants to collaborate on research and has access to grant funding, let me know after the talk. Cancer and suicide. So unfortunately, again, we know that cancer patients are more at risk for suicide relative to the general population. And a lot of the reasons for that can vary. So there was some concern that a lot of it could be untreated depression. There's also, too, we know that people who, patients may feel hopeless. There's patients who talk about wanting to go out on their own terms, especially uncontrolled pain. Things like that can all be risk factors. We do hear a lot of patients talking about passive thoughts of death. And, within our role, it can be that's an important area to kind of flush out, because it could be, patients say, well, of course I think about dying, or I have patients that are physically suffering and say, I think about not waking up in the morning. The distinction is they wouldn't do anything to end their life, but we want to, treat that as importantly as we would as if they said they were having thoughts of ending their life. I'm going to skip this, but if anybody wants to talk about medication in this area, let me know. So sexual dysfunction and cancer, again, what we love in psychology is our huge variance, but rates of sexual dysfunction can vary quite a bit, even up to 100%. I would make the argument that if you're looking at any aspect of sexual dysfunction, you're probably a lot closer to 100%. So whether that's issues with functioning, with libido, with desire, there's going to be some change to sexual functioning during or after treatment. It arises from many factors. Like I said, there could be a physiological reason why patients are not able to function within their sexual relationship the way they did before. Psychological factors, depression, patients who maybe have a changed appearance because of their cancer, or social factors, which I'll get into some of the couples pieces as well. So specifically in women, of course, a lot of research has been in breast cancer. We know that the extent of surgery, so was it a lumpectomy where just, a portion of the breast or just the area where the mass was removed, versus a mastectomy, a unilateral versus bilateral mastectomy, can be especially problematic for younger patients. Gynecological cancers also extremely common in that area. And we know that a lot of the medications which are used to treat hormone-based cancers can cause premature menopause, which in and of itself, menopause can create some sexual functioning concerns. With men, a lot of studies obviously look at prostate cancer. I think that's probably the most well-studied. Again, 25 to 90% have some kind of sexual dysfunction after treatment. For prostate cancer, androgen deprivation is common, so it helps with survival but can decrease quality of life, libido. And some of the common issues, men will report erectile dysfunction, difficulties with orgasm, or just a low libido. And then kind of a bidirectional relationship between these factors and the sense of themselves and their masculine identity can be all wrapped up in that as well. So when we assess this, I know it's difficult. A lot of our students, it's uncomfortable to ask about. I think also too, we have a perception that that's a specific training area, right? I don't know what to do to treat that. A lot of times if we treat the psychological, the couples-based issues related to that, sexual functioning, either sexual functioning itself can improve, or patient satisfaction with the level of sexual functioning they have can improve. So in general, it's kind of this don't ask, don't tell culture. Patients may be uncomfortable even discussing it with their spouse. And I think this is, again, directional both ways. I think the caregiver may feel guilty for, and I say caregiver, but spouse, partner may feel uncomfortable bringing it up. Okay, my partner is going through this cancer treatment. I can't mention that I'm dissatisfied with our sexual relationship, or the patient themselves may feel guilty bringing it up. So some of the models, the PLICIT model is well known. Permission, so asking the patients to discuss. We make this one of our questions we do in our psychosocial assessment, so it's just routine. We ask about mood, we ask about sleep, we ask about sexual functioning. providing some education, which I think in this context is mostly just normalizing it. So even if you remember that, you can tell patients, some studies estimate up to 90% of men treated for prostate cancer have some degree of sexual dysfunction. That can be really help patients not feel so alone. Giving some specific suggestions, so like sensate focus, where patients work on intimacy without intercourse, or recognizing when it's appropriate to refer for more intensive therapy for patients. This is where it's really important to consult with medical providers, so referring patients to a urologist, a gynecologist, to make sure that there's no physiological or hormonal issues. If that's been addressed and there's still concerns, you can look at CBT, so tapping into some of the maladaptive thoughts, unreasonable expectations, so people will struggle with it's not like it was before, and helping them to adapt the ways in which it's changed but can actually be improved. I talk to patients sometime about grieving the loss of their normal functioning, the loss of their past self. And again, just restructuring to think about what's, example for women who have had a mastectomy, what sexuality can mean without having breast, and how the breasts themselves don't define or 100% define how they see themselves as a woman. We use a lot of mindfulness in cancer distress. Again, I'm preaching to an audience who buys in, but we know that mindfulness-based techniques are helpful. There's some evidence, too, that it can be really helpful when you apply it to fears of recurrence, which are really common for patients. So the idea of being mindful in the present moment, like we know this recurrence is here, we know these worries are here, but right now in this moment, you're cancer-free. And helping patients to fully live in that moment instead of the what-ifs of 3 months, 6 months, a year down the road. I mentioned, again, a little bit about this when we got into the sexual dysfunction. I know this is a big slide, and I know I'm quoting myself, which is kind of lame, but I like the way we designed this study. So looking at caregiver distress, we looked at the BMT, which is bone marrow transplant population, and we assessed patients and, in this situation, it was spousal caregivers, and we assessed them prior to transplant, 1 month and 6 months after, and we found some interesting dynamics both between gender and role. So again, I won't go into all of this, but that female caregivers, their distress was more impacted by financial or vocational, meaning work-related concerns, whereas men were not. Women who work may be more impacted by being caregivers. So I think, and I hate to do like gender wars, but there's a lot of studies that talk about the disconnect in the majority of households between, and this would be in, heterosexual relationship households, where women tend to do, a study I just saw was double the amount of kind of household work than the men in the household do. I think there's also too, and this is just clinically what I hear, is, when it's the woman who's the patient, a lot of the male caregivers, family members step in to help take care of the kids. They drop off food. And again, in talking to some of my female caregivers, either maybe they struggle in asking for that or using that kind of help, but it just doesn't seem like the same logistical help may always be there, and that could be because of our perceptions of what kind of help people need. And we also found, again, that role matters when it related to distress. So caregivers' distress was affected more by healthcare adjustment, meaning like how comfortable did they feel within the healthcare setting, asking questions, advocating for needs. And that relates to physician attentiveness, empathy can help reduce distress. So we'll see caregivers, wanting to ask questions. And the other hard thing too is caregivers assume the responsibility of caring for the patient. So patients may have really complicated regimens. And I always, help to normalize caregivers because in the hospital they have PCTs and nurses and doctors and housekeeping and nutrition and PT and OT. There's this whole team that cares for the patient. And then one day they just decide to send the patient home, and potentially one caregiver is responsible for all of that. But when they feel like their healthcare team is answering their questions, is attentive, that can help decrease their distress. So couples interventions can be really effective in this setting. We know that improving communication within the couple can improve or can decrease distress. And again, another bidirectional relationship. Relationship factors can be protective against cancer-related distress, and helping to treat cancer distress can improve the relationship. We know that untreated, unfortunately, can lead to risk of separation. So the stress, the perception of, you weren't there, you couldn't meet my needs, can lead to separation. Again, more interventions that we can do with patients. Sometimes it's as basic as psychoeducation. So especially on the inpatient side, vast majority, very few of the patients we see have ever had therapy before. Very few of them, whether there was a need or not, would have ever walked through the door of a mental health office if it weren't for the cancer. When we're consulted on patients inpatient, we just walk into their room and start talking about this. So sometimes, patients don't even know how to recognize their emotions. So we do education on labeling what is anxiety, what does it feel like, providing psychoeducation on sleep hygiene, strategies to manage pain, the role of exercise, behavioral activation, giving them social support groups. Those kinds of things can be really powerful. Communication, and this is something, again, that we work a lot with the physicians and providers on. So a common recommendation that we put in our notes is for patients that we have concerns about their low health literacy. We'll sometimes hear from providers, the patient just doesn't get it, or they're non-adherent. And then when you talk to the patient, it's issues with either general literacy or health literacy, which is its own separate entity. So using the teach-back method, asking the patient to repeat back what they understand. Or I like this terminology, living room language. So just casual conversation, minimizing use of medical terms as much as possible. And helping, and I think now medical schools do a much better job about training and teaching empathy, but we know that perceptions of patients that their physician cares about them can actually decrease trauma and distress. And like I said, for patients who have shared with me that their diagnosis itself was a trauma, the factor that I think is present in every one of those circumstances was that the way it was delivered had no empathy. A provider walks into a room and just bluntly states it or gives a poor prognosis without the sense of empathy or concern for that person's well-being. Presenting recommendations as a choice, which helps patients maintain a sense of control. And again, helping to validate their distress. So there's another interesting study I saw that was looking at, again, anxiety during radiation. And they found that patients reported less anxiety when the staff would focus on what they can do. So for example, instead of saying, don't move your leg or don't move your head, it was, you can move your fingers if you want. Letting them know what they could do was really empowering for the patient. So getting into some of the end-of-life care, we know that there's phases, right? There's pre-diagnosis where symptoms are being worked up. Then there's the acute phase. It's the diagnosing, making treatment recommendations. Chronic phase where you're going kind of through treatment. You may be in periods of remission, recurrence. Again, some people will recover, or some people, will transition into the terminal phase where we know that death is inevitable soon. I know this sounds strange, but people die in different ways, and there can be challenges associated with each. So there's a gradual slant, if you picture just kind of a long, slow trajectory. Challenges is that suffering happens for a long time. There's a progressive loss of functioning, and it can drain resources, financial, emotional. There's a downward slant, which is more of kind of a rapid decline. We see that sometimes, patients diagnosed with a end-stage disease or who have another complication and die within weeks or even months of that diagnosis. The patient, others feel they don't have time to prepare. There can be peaks and valleys, where patients decline, then they go into remission, they feel well, relapse, and, it kind of changes over time. The issue is, people talk about being on an emotional roller coaster. So they're celebrating remission and then grieving relapse, and it gives a little bit of hypervigilance about not knowing what to expect. Or descending plateaus. So those look more like people will have a decline, they kind of stabilize within that decline until the next decline. And again, similar to the peaks and valleys, it's adjusting to the changes in function, but over a longer time, and that there's this progressive ongoing loss of functioning. So I know it seems like distress is inevitable in patients with terminal illness, but that's not always the case, and we know that there's things that can make that distress more acute. Symptoms aren't managed, if they have altered mental status, if they're confused, if they feel hopeless or helpless, also being younger, other life stressors. I put avoidant coping sometimes because we see this again as another consult, patient in denial. Right? And so when I talk to patients, especially those with a poor prognosis or end of life, I always talk to them, and right or wrong, this is kind of how I delineate it. If they're doing the right things, right? If they've got their POA lined up, if they've talked about what they want for code status, if they've addressed relationships, like they've done all the things to indicate they're aware of their foreshortened life, but they're choosing to talk about seeing their daughter graduate in 5 years when everybody knows there's nearly a 0% likelihood of that happening. That to me speaks to somebody who just needs to think that they're going to be there for their daughter's coping. Everything they're doing indicates they're aware that's not going to happen, but if that's how they're coping, I don't really feel like it serves any purpose to take that from them. Limited social support's another risk factor, again, or history of psychiatric illness or substance abuse. So sometimes it can be hard to distinguish what's grief and what's depression. We think about sometimes for patients anticipatory grief when they're grieving their own inevitable death. We think of grief somewhat as anticipated and actual, whereas depression has more of the kind of somatic, affective symptoms that we see. Grief, again, normal and expected. And depression we don't think of as inevitable. So I tell people, yes, depression is common, but it doesn't mean we don't still need to treat it. People may be withdrawn. I think you see more of the giving up or the hopelessness, helplessness with depression. Patients with grief can still receive pleasure from things. The grief may come in waves, whereas with depression, you may see that decreased enjoyment. And treatment, again, we may think about more medications for depression. If grief's not impacting quality of life, may be more responsive to just acknowledging it. Again, a lot of patients, their friends and family don't want to talk about it. And, patients have a need to make sure people are going to be okay after they die. So they'll try to talk to their spouse, their partner, and say, give them what they want for their life. I want you to find somebody else. I want you to take that trip we always planned about. And unfortunately, their family members, because they just don't want to acknowledge it, will say, no, don't talk like that. Don't talk like that. And unfortunately, that kind of closes the door for something that can be really powerful for that patient. So we might be the outlet that they can talk about those things. I mentioned the anticipatory grief. We know the different concepts of stages of grief. I want to get to, so I realize that this is kind of blurry, but I hadn't heard about this during my graduate training. It was only recently as somebody talked about this dual process model. And the idea that we kind of vacillate or oscillate between loss-oriented behavior and restoration-oriented. So loss-oriented is focusing more on the feelings of grief that, people feel sad, but then the restoration that sometimes they do new things. And this is, people at times will tell me, let's say it's a partner of a patient who's died, like, I feel guilty going to our granddaughter's recital. And that's when I like to talk about this model, that this is how grief can exist. There's times that you're more focused on today and tomorrow, and then there's times you're more focused on the grief of what will come, and that's normal, and it doesn't imply a lack of regard or a lack of care. It's just a normal experience with grief. So I find that psychoeducation piece can help people kind of forgive themselves. So communicating with patients and families, again, some specific questions to ask, what do you think is ahead? How do you understand your illness? How have you coped? Who are the important people in your life? Specifically when you're focusing on end of life, that can be a time that people want to restore, fix relationships, finding out like what that would look like. Asking about stressors, do you have the things you need at home? Are you worried about, your spouse being able to pay the bills after you pass away? Of course, asking about history of mood concerns again, and then faith can be really important for some patients at this time. So what is a good death? Making sure the patients are physically comfortable as possible, helping them feel that they are still themselves, right? That they're not just a body or not just a patient. Helping to build or even enhance relationships, making meaning out of their life or even sometimes out of their death, having a sense of control, even if it's on a really small scale, and being able to feel that they could prepare for their death. So when you're doing therapy or treating patients who are dying, I think avoidance is the most important thing to watch out for. And I know I'm guilty of this too. So, when I'm planning out my day, if I have a patient that's end of life that I need to see, I very consciously make sure I'm not putting them to the last of the day or looking for an easy out, right? Which is easy to do, like, oh, somebody else is in the room. I tried today. I'll come another day. And checking in with myself about, is it just me avoiding the challenge or the emotional impact of working with this patient? Being aware of your own countertransference, reminding yourself that it's going to look different than normal therapy. There's not really a lot of evidence-based protocols. You may not always be talking about death. You may not always be doing a CBT intervention. It may just be talking about that person's life, because when you don't have much of a future, you can't help but do looking back, and it can be incredibly rewarding to just talk to the person about who they are, and notice your own grieving and guilt. You get close to certain patients. Patient may remind you of your parent. The patient may remind you of yourself. And just being aware that, and validating, because again, students will say, I only knew them for X number of weeks or X number of months, or I'm not a family member, kind of invalidating your own experience, but you are still a person who had a relationship with another person, and that person is dying or has died, and just kind of being aware of your own experience at that time. So, why would I work in this area after all this depressing talk, and why would I hope some of you want to as well? For those of you who are in the field, maybe you can share your experience, but think it is the most rewarding area. I mean, you literally have the range of the human experience when you work in oncology. You see people at their absolute worst and you see them at their absolute greatest. Depending on your setting you work with other providers who are as passionate and dedicated as you are, and that's inspiring in and of itself. And I think even on the worst days, the saddest days, there's still a sense that you matter to that person. And I always, I think about the fact that, when people are in that situation, a lot of people are going out of their life and we're kind of going towards. And so I just think that's such a powerful role to hopefully be able to play in some patients' lives. So I promise it is worth it, even when it's hard. So, so let me know. I don't know, Zoe, if you were going to read through any questions or how you want to handle that.
So I think I was waiting to see if there would be any questions in the chat box, but we could also leave this as an open kind of discussion to do questions or comments. I think there's a lot of things that we could talk about. It was a great presentation. So if you'd like to ask a question or make a comment, just go ahead and then we'll just try to have one person talk at a time. Well, I would like to make a comment, which is that one of the issues that I've struggled with psycho-oncology is the lack of evidence-based treatments and how there can be a difference between like adjustment to a really difficult illness and changes in your body versus clinical depression. And I think that your presentation did a really nice job of talking about how you navigate some of that and how you conceptualize the cases that you work with.
Oh, good. Thanks. Sometimes I feel like we just validate that it's an issue and we don't really talk about what to do about it. But you're right. I think it is a challenge in this setting to tease everything apart. So if anybody does have questions or want to talk more about working in this area, feel free to send me an email and I'm always happy to talk more.
Great. Well, thank you all so much for joining today. And we will be posting the recording at some point in the near future. So if you weren't able to make it today or somebody who wasn't able to make it. And we just want to thank you so much for your presentation today. And we'll be back next week for the Business of Health Psychology.
Okay. Thank you.
Thank you. Thank you. Thank you.